Welcome to this introductory video on the use of radiofrequency ablation in obstetrics, or RFA. My name is Dr. Voon RFA. Briefly, RFA involves the generation of heat and subsequent coagulative necrosis through radiofrequency waves. These are some of the indications of RFA, largely for selective feticide in monochorionic twins. Now, unlike in dichorionic twins, the use of intracardiac potassium chloride in monochorionic twins is contraindicated due to the transplacental passage of KCl to the co-twin. In singleton pregnancies, it has also been used as a treatment option in giant chorioangiomas. There are various lengths in the RFA probe, and here 15 cm represents the whole length of the needle and 1 cm indicates the active end of the electrode. There are markings on the needle 1 cm apart. The size of the needle that we're going to use today is 17 gauge. This end will be plugged into the RFA system. These channels allow cooling saline to be connected to the peristaltic pump. This is the RFA system. The duration of each cycle is shown on the top right panel. The second assistant needs to adjust the impedance control during the procedure to deliver the targeted energy. You can see the peristaltic pump located at the bottom left of the screen. The system is completed by a grounding pad placed on the patient. This is the layout during the procedure, which can also be done under local anesthesia. The surgeon stands opposite the ultrasound system. The first assistant's role is to handle the ultrasound machine. The RFA machine can be placed next to the surgeon, but I preferred it in the opposite direction so that I can view the cycle duration and energy delivered. Our patient today is 16 weeks pregnant with a trapped twin, which is relatively large compared to the pump twin. Sometimes such cases are mistaken for a demise twin, as there is no fetal heart seen. Here, we want to identify where the cord inserts into the fetal abdomen. You can see the pump twin on the right side. The fine dotted lines here indicate the trajectory when you are using a biopsy guide. This was the initial insertion of the needle into the fetus using a biopsy guide. We were not satisfied with the position, therefore the needle was removed from the fetus while maintaining it within the subcutaneous tissue. My movement here was restricted by the biopsy guide. Therefore, we removed it to allow a greater range of movement. With the needle still sitting in the subcutaneous tissue, we re-angle it to the target where the cord inserts. The ablation is started. You can see how there is intense Doppler signal at the tip of the needle. We use initially 50 watts for 1 minute, then 70 watts for 2 minutes in the first cycle. There is no fetal cardiac activity in the trapped twin, which means it cannot be relied upon to determine completion of the procedure. At the same time, don't forget to check on the pump twin during the procedure between ablation. Each subsequent ablation cycle is for about 2 minutes and will perform at 70 watts. Now typically, 3 to 4 cycles are required to complete the ablation, although some authors have reported up to 6 to 8 cycles. I'm going to leave this video to play for a while in real time. Even without actively ablating, the tip of the needle here can also throw off artifacts on Doppler, which is quite chaotic, as you can see here. When we are finally happy with the cessation of flow in the cord into the baby, the needle is removed. In terms of safety, there are several things to keep in mind. The energy used is 50 watts for the first minute, then 70 watts for each 2-minute cycles. If you require higher energy, it's time to pause and troubleshoot. Similarly, if higher than anticipated number of cycles are required. The reason for the initial gradual increment is so that the rapid rise in temperature is avoided, as this can cause charring and resulting in insulation effect from the charred tissue. In this procedure, I used the RFA 1510, a single electrode with a 1 cm active tip. It has an active ablation zone of 1.2 to 1.3 cm. In larger fetuses, a longer active tip may be chosen. Other devices are available, such as the Rita Starburst, which does not have MDA approval to be used in Malaysia. Now, this device has a channel for infusion or removal of fluids. In addition, it has tines which allow a wider spread of area of ablation. Now one has to be careful, as the opening of these tines may go beyond the target area, which has been associated with additional complications. Here are some things which I think is helpful for the initial learner. Use a branula rather than a blade for stab incision, especially if a biopsy guide is used. I also find that using the biopsy guide is only helpful during the initial entry to prepare a trajectory, as it may be restrictive when finer adjustments are needed when you approach the fetus. Be prepared to remove it to allow free hand movement. The procedure is usually done after 16 weeks, although there are some reports of it being used as early as 13 weeks without increased complications. Once the RFA needle is inserted, there may be chaotic artifacts on the Doppler, which can be confusing in inexperienced hands. Preoperatively, it's best to identify a loop of cord for assessment of completion of the procedure, because some fetuses, such as in our case, do not have a fetal heart pulsation to begin with for you to check on. Allow me to acknowledge the maternal fetal medicine team for the filming and editing of this video, and the mentorship from our lead MFM, Dr. Rafai Amin. Thank you very much. I hope you enjoyed watching this.